Hello, welcome to our lightning presentation. Our study is an educational module to improve knowledge of delirium screening in the emergency department by Sarah Minion, Brooks Ober, Ryan Carnahan, and Sangol Lee. So the authors have no financial conflicts of interest to disclose. So a little bit of background of delirium in the emergency department. Delirium is an acute condition characterized by reduced awareness, emotional disturbance, and mental confusion. Delirium increases morbidity, mortality, healthcare costs, and hospital stay duration. It affects 7 to 10% of elderly patients in the emergency department, but is diagnosed in only 1 of every 6 of those patients. So why isn't delirium screening widely used in the emergency department? Provider time constraints, insufficient training in delirium screening tools, as well as the lack of a universally used diagnostic assessment tool. So the research goal and objectives of our study, the research goal was to improve knowledge of available delirium screening tools in the emergency department. The objectives was to implement a delirium screening educational module, to assess whether the delirium screening education module significantly improved emergency department provider knowledge, and to assess whether users believed that the module was a beneficial educational tool. So the methods, this setting was the University of Iowa Hospitals and Clinic in Iowa City, Iowa, from December 2019 to August 2020. The population was all physicians, residents, advanced practice practitioners, pharmacists and nurses listed in the University of Iowa Emergency Department listservs, as well as residents or students who rotated through the emergency department during the study period. So the first part of our study was the online delirium screening educational module. This module included delirium epidemiology in the emergency department, clinical presentations of delirium, and explanations of the process of screening potential delirium patients using the Brief Confusion Assessment Method, or BCAM. It also included a pre-test, a post-test, and a demographic survey. The second part was a post-module survey to assess users' reactions. And the statistical analyses that we performed were descriptive statistics, as well as Wilcoxon matched pairs signed rank test for the pre-test versus post-test comparisons due to the non-parametric nature of the data. So this is the results of the education module pre-test and post-test, percent correct. On the left in the blue is the pre-test scores, the median being a 40% and the IQR being 30 to 60, with scores ranging from 0 to 100. For the post-test, the median was 100 and the IQR was 80 to 100, and all participants in this part of the study scored between 80 to 100, which is why there are no whiskers on the box plot. So this is the survey results with the second part of our study, the end user survey. The questions were: the module enhanced my knowledge of the subject matter. The module was relevant to my job. The delirium screening tools described in the module are easy to use. The module training significantly impacted the way they cared for patients. It was an effective use of their time. The pace and delivery method was appropriate, and that they would recommend the module. And they ranked it from 0 being strongly disagree with the statement to, or 1 strongly disagreed to 6 strongly agreed. And the values for those survey questions are in the figure on the right. And all the median of all the responses was 4 or above, which correlates to slightly agree. So all responses were slightly agree or better, but ranges differed for each of the questions. So the conclusions for our study: participants significantly increased post-test scores from pre-test scores, indicating that they did receive educational benefit from taking the educational module on delirium screening tools. Also, the survey participants communicated overall positive reactions to the education module, as well as indicated that they had started initiating the use of delirium screening in their respective practices. So future research. Future research should seek to determine whether educational modules improve delirium screening in practice, as well as if they improve outcomes in emergency department patients with delirium. That ends our presentation on our study of educational module to improve delirium in the emergency department. Thank you for listening.
Hello, thank you for allowing me to present my work today. My name is Andrew Golden, and I am one of the medical education fellows at the University of Chicago. And today I'll be presenting my research entitled Evaluating the Core Emergency Medicine Entrustable Professional Activities Using the EQUAL Rubric. I have no disclosures. The ACGME core competencies were developed as part of the integration of competency-based education into residency training programs in the late 1990s. Many of us are familiar with these as they, in combination with the milestones, form the basis for much of the assessment that we perform for our resident learners. But the challenge is that they describe the attributes of a learner, making it hard to actually observe and assess these characteristics in the workplace. So as an alternative or perhaps complementary approach, Olayton Kate proposed the use of entrustable professional activities in the mid-2000s. He described these as core units of professional work identified as tasks or responsibilities to be entrusted to a trainee when sufficient competence has been reached. Of course, as we all know, the AAMC has created the core entrustable professional activities for entering residents, and many graduate medical education training programs have also created EPAs, including in emergency medicine, which you can see on your screen here. These were published in 2019 as the product of a core working group who set out to identify the core emergency medicine EPAs for residency training programs. Ideally, these EPAs would be much easier to observe in the clinical environment, much easier for supervisors to assess, and easier for us to provide feedback. But after their publication, there's really been no research to further evaluate these or describe their integration into training programs. One method of evaluating EPAs is through something called the EQUAL rubric. This is a tool that essentially compares EPAs to standards that have been published in the literature for EPA development. It has 14 items that are grouped into 3 separate categories, and each of these items is scored on a 5-point scale with individual anchors for each item. It's been validated in 2 separate studies, one in looking at Canadian internal medicine EPAs and the other in the AAMC core EPAs for entering residents. But one of the benefits of this tool in particular is that the authors in its initial validation actually set a cutoff at which any EPA scoring below that cutoff was thought to require revision or need for review. That was developed via Angoff approach, and that cut point was set at 4.07, and we'll talk more about that later. But ultimately, the purpose of my study is to compare the proposed core emergency medicine EPAs with those published standards as measured by the performance on this EQUAL tool. And additionally, I hope to evaluate the reliability of this tool in a new group of clinician educators in emergency medicine. In order to do this, I asked clinician educators from 2 different academic institutions involved in UME and GME training to participate in this study, and they were required to watch an instructional training video before they then applied that 14-item rubric to the 11 core EPAs. Again, each of the items on the rubric has different different anchors. And so I translated all of those to ordinal numbers on a scale of 1 to 5 to be used for data analysis. Higher scores, therefore, indicate higher alignment with these published standards. And just for this part of the study, I performed basic descriptive statistics. Overall, the average score on the EQUAL rubric was 3.89 when looking at all EPAs together. But when looking at them individually, 6 of the 11 EPAs, or 55%, scored below that 4.07 threshold, which you can see as the red bar at the top of this graph. And those items were number 4, manage a high acuity patient with a well-defined presentation, illness, or injury. Number 6, manage multiple patients in the ED concomitantly. Number 7, lead an ED team. Number 9, manage interactions with consultants. Number 10, manage complex and difficult situations. And number 11, use recommended patient safety and quality improvement processes. And while I don't present this data here, I try to identify why these EPAs fell below that threshold, and most of them were scored poorly on 2 items on the EQUAL rubric, one being having a clearly defined start and end point, and the other being that they are independently executable to achieve a defined clinical outcome. Now, in order to look at the reliability of this tool, I calculated intra-class correlations using an average rating two-way mixed effects model measuring consistency. And overall, I found the reliability to be good at 0.729, which is similar to the reliability published in the initial validation study of this tool. Two of the items had excellent reliability as seen in the green cells, and four of the items had poor reliability as seen in the red cells. And you'll see that most of those fall into that subcategory of evaluating the utility of EPAs or their role in curriculum development. So overall, more than half of the emergency medicine EPAs fell below a predefined threshold, suggesting that we should review or potentially revise them before they're implemented. Additionally, this rubric does have a good reliability in this group of EM clinician educators, but we may need other methods to evaluate how EPAs can be used as tools for curriculum development. Thank you very much for your attention and your time, and I'm happy to take any questions at the end of all of these presentations.
Hello, everyone. My name is Brandon Hefke. I am a PGY2 resident in the Mayo Clinic Emergency Medicine Residency. And for the next 6 minutes, we're going to talk about my abstract, which is titled Defining the Clinical and Procedural Opportunities Available to Residents During Rural Rotations. Before we start, I just want to say a quick thank you to Dr. Hami, Dr. Scholes, and Dr. Jones, who are all attendings within emergency medicine here at Mayo Clinic, and Catherine Yang, who's a second-year medical student in the Mayo Clinic School of Medicine. These were my co-authors. So the reason this study came about is that our program is one of many that sends residents out to rural locations as part of their educational curriculum. Specifically, this is Rochester, Minnesota, which is the site of our academic center. And just southwest of there, we have 2 sites, Austin and Albert Lea, Minnesota. These are towns of about 20,000 people that have EDs associated with Mayo Clinic that are single provider coverage. And residents spend 1 or 2 shifts here a month on a longitudinal basis over the course of their residency. And we do this because we think there's a lot of benefit. There's procedural opportunities when you're away from the learner pressure of an academic center, as well as soft skills like resource allocation. And based on all those, we sent our residents out, and we wanted to actually use a research study to kind of inquire or demonstrate some of these actual benefits to residents as has not been studied previously. So what we did is we performed a retrospective chart review of all the resident patient encounters that were generated during the academic year of 1920 at those 2 community sites that I showed you. So before we got into the charts, we generated a list of clinical and procedural experiences that we wanted to try to capture while our residents were out there. We determined these with an expert panel that included our program director, the attending that is in charge of this experience for the residents, as well as several other attendings that split time between community and academic sites and determined things that we thought residents did do or we'd like to see them do. And this is the list we came up with. Just to orient you, these things here in the top left are things that our residents are not typically doing in our academic center for a variety of reasons, including learner pressure or just not the opportunity to transfer patients. And then things here on the right are things that happen in our emergency department on a daily basis, but are completely different experiences when you are doing single provider coverage out in a rural location. For instance, the trauma activation is very different when there's no trauma surgeon or operating room or anesthesiologist, and you're the single provider that has to think about and do everything on your own. And here in the bottom left are some other standard emergency medicine procedures that we wanted to capture for baseline data as well. So once we generated those CPEs, we went through all the resident encounters during the academic year, which was just over 1,300 patient encounters. And for each one, we used predefined criteria to decide whether a CPE was performed or experienced or not. And then we also calculated the total number of hours that the residents worked cumulatively at those 2 community locations. And we used that to calculate the expected number of CPEs per shift as they occurred. So here's some of our results here. Those are the same CPEs I showed you now in descending order of frequency. And this is the number of experiences divided by the number of hours worked multiplied by 12 because we work 12-hour shifts. To show you, for instance, that transferring a patient out and filling out those ambulance forms is happening more than once per shift out in the community during that year, whereas critical care time is happening perhaps once every other shift or half a time per shift. Perhaps a more intuitive way to look at this is actually the inverse. And so here is the number of shifts a resident would have to work in order to be expected or predicted to have one experience. So to show you the same thing here, a resident has to work less than 1 shift in order to be expected to transfer a patient out. A resident working 2 shifts would be expected to have bought opportunities to perform critical care in the community, and a resident working 5 shifts would be expected to have an opportunity to place a splint or a cast on a patient, and so on. We did calculate confidence intervals. These are for the experiences per shift over here, and all are within reasonable ranges, thankfully. I think there's a lot of strengths to this study. For one, it's a really large sample size, and we actually measured the entire population that we were studying, and that every patient that was seen by a resident in our community sites during that academic year, we looked at every single patient encounter. And this was not reliant on resident self-reporting. We weren't waiting for them to put it into some logging software. We actually looked at the chart and decided on our own, did they have this experience, yes or no? There was, of course, limitations to this study. This was in a single health system center and was limited in geography to Southeast Minnesota. So based on the incidence of these diseases and other places, the frequency of experiences could go up or down. It was, of course, retrospective in nature in that these patient encounters occurred before we generated this data. And there was only a limited number of events captured. We initially had a longer list of events, but we decided to focus on the ones that we thought would be the most high yield. I think what we can conclude from this data is that there's a lot of good experiences that residents get when they go out in the community. If you send your resident out for 20 or 30 shifts over the course of residency, they would certainly be predicted to do the things that are above this line here, which would be great experiences for residents. And many of the really critical ones, like transferring a patient, fracture care, are expected after just a couple shifts. Our future plans for this study is to take the same CPEs for our academic center with the same residents over that same period of time and see perhaps is there any superiority for these experiences in the community sites versus in academics. So that's my presentation. Thanks so much for watching, and I hope you enjoy the rest of the conference.
Hi, my name is Dr. Danielle Miller, and I'm presenting the abstract Simulation-Based Mastery Learning Improves Use of Personal Protective Equipment by Medical Students. This is brought to you by Stanford Department of Emergency Medicine, and the authors have no disclosures. Students are routinely exposed to blood, bodily fluids, and other potentially infectious agents during clinical rotations. To prevent dangerous occupational exposure, students must learn the proper technique for donning and doffing personal protective equipment. Recently, the coronavirus pandemic placed further demands on medical schools to standardize PPE training for students. Despite these mandates, research shows that medical students receive inadequate training in PPE use. And PPE training programs commonly lack requirements for demonstration of actual technical proficiency. A study of PPE donning and doffing skills found that 92.5% of medical students had one or more lapses in procedural technique. And traditional teaching modalities such as computer-based modules, videos, lectures, other PPE training approaches used by occupational health services fail to adequately prepare medical students for the clinical environment. However, we know that simulation-based mastery learning improves medical student performance of a wide range of procedural skills, including peripheral IV, insertion, chest tube, thoracostomy, LAC repairs. But to date, there have been no studies examining the use of simulation-based mastery learning to teach PPE donning and doffing procedures to medical students. So the objective of this study was to determine if simulation-based mastery learning improves proper PPE donning and doffing by medical students. The primary outcome was student performance of procedural technique as assessed by a previously developed checklist. And then secondary outcomes included a comparison of performance by students with and without previous clinical exposure. The methods, so this was a prospective pre-test, post-test study of 155 medical students on demonstration of correct PPE use before and after a simulation-based mastery learning intervention. Subjects first completed standard hospital training by viewing a CDC training video on proper PPE use prior to the intervention. They then participated in baseline testing in which they were assessed using a previously developed 21-item checklist on donning and doffing PPE with a minimal passing standard of 21 out of 21 items. They then completed a simulation-based mastery learning training session, which included deliberate practice with expert feedback. And finally, they completed post-testing until mastery was achieved. Differences between pre-test and post-test scores were analyzed using paired t-tests, and then baseline tests of students with preclinical versus clinical levels of training were compared with independent t-tests. Here's the demographic information for participants. You can see at the bottom that we had both preclinical and clinical students participate. And of note, only 62.9% of students reported previous formal hands-on PPE training. Of 168 eligible students, 155 completed baseline testing. Only 2 participants, or 1.3%, met the minimal passing standard on pretest. Of the remaining 153 subjects who participated, 151 reached mastery, and then 2 did not meet mastery in the session times allotted. And there were no differences between pretest scores of the preclinical versus the clinical students. Comparison of mean scores from pre-test to final post-test significantly improved from an average raw score of 12.55 out of 21 to 21 out of 21, which was statistically significant. So this study demonstrates the effectiveness of simulation-based mastery learning to teach PPE donning and doffing technique to medical students, and adds to the growing body of literature supporting the use of mastery learning as the gold standard for teaching bedside procedures. Only 2 subjects met the minimal passing standard at baseline testing for proper PPE use. Thus, these usual medical school and hospital infection control training, which includes maybe ad hoc clinical instruction on the wards or mandatory viewing of videos, fail to prepare students for proper donning and doffing. And these are very concerning findings, especially in the light of the ongoing coronavirus pandemic. It really is imperative that medical schools improve PPE training to better protect their students. I think 2 features of simulation-based mastery learning likely contribute to the achievement of a mastery standard in this study. And first, simulation-based mastery learning incorporates deliberate practice with expert feedback. And secondly, simulation-based mastery learning includes proficiency testing students, and we know students perform better when they know that they'll be tested on it. Future studies will have to evaluate if computer simulation for procedural training or maybe VR training are equally as effective as simulation-based mastery learning. So in conclusion, simulation-based mastery learning improves medical student competence in PPE donning and doffing in a simulated environment, and this approach standardizes PPE training for students in advance of clinical experiences. Here are references, and we'll now open it up to questions.
Hello everyone, my name is Stephen Villa and I'm a second-year medical education fellow at UCLA. And today I'm excited to talk to you guys about our study titled EM Residency Radiology Education, a National Needs Assessment. None of the authors in our study have any conflicts of interest. So why are we looking at this? Well, radiology instruction is important, but its delivery has been variable in undergraduate and graduate medical education, ranging from informal teaching to required educational experiences. And this variability in exposure and training may lead to varying provider competency. In the acute settings, such as the ED, rapid and accurate interpretation is critical. Prior literature has shown wide variability in radiologist and emergency provider concordance with respect to interpretation of studies, which raises questions on the accuracy of interpretation by ED physicians. This may be due to inadequate training for such tasks. In fact, a recent survey of EM attendings found that only 30% felt prepared to independently interpret plain films on their own at graduation from their residency. In 2015, members of SAEM, along with members from several radiology organizations, met and agreed that the ability to both select and interpret diagnostic imaging is an integral skill for ED providers, and therefore recommended that a diagnostic imaging curriculum, as well as tools to assess competency aimed at emergency medicine residency training, should be developed. Therefore, a needs assessment is the crucial first step to improving radiology education amongst EM residencies. So the objective of our study was to explore the current state of radiology education in EM residency programs. And so to do this, we performed a cross-sectional survey study of all ACGME programs in the United States. We surveyed program leadership in a stepwise fashion with an online survey. We first sent out surveys to program directors 3 times at weekly intervals, and if they didn't respond, we then moved on to associate program directors, subsequently assistant program directors, so on and so forth, until we got a response. Once we got a response from a given program, we stopped contacting faculty from that site. Contact information was obtained from ACGME, SAEM, and cord listservs, as well as websites. And the survey that we sent consisted of 16 items, 7 Likert, 8 multiple choice, and 1 free response item. And descriptive statistics were calculated and reported. At the time that we started our study, there were 252 available ACGME EM residencies, of which we received 142 responses, which accounted for 56.35% of the residency programs in the United States. As you can see in the table, we had good representation and broke it down by program format with 105 responses from PGY 1 through 3 year programs and 36 responses from PGY 1 through 4 year programs. For those who can quickly do math, those numbers add up to 141 programs. We had 1 respondent who opted out of the demographic portion of the survey. We also broke it down by primary clinical site. And as you can see, we had representation from county, university, and community programs. The others were respondents from programs that had 50% of their time at county or academic, so multiple primary clinical sites. And we also broke it down by program region, with the Northeast region being the most represented region in the country for our study. We found that 88 out of 142, or 62% of respondents, reported that their programs did not have formal radiology instruction. Of the instruction that was provided, about 89% was given via didactics or lectures, and 81% relied on instruction that was given during clinical shifts. 36% of respondents reported that they had asynchronous opportunities available, and 16% had a dedicated radiology rotation. We also found that 95% of respondents felt that it was extremely or very important for ED providers to be able to independently interpret X-rays specifically. 91% either sometimes or always relied on their independent X-ray interpretations, which may shed some light on why they felt it was so important to be able to interpret those studies. And when asked what were the most important studies for ED providers to be able to independently interpret, specifically for X-rays, respondents reported X-rays for lines and tubes, chest X-rays, as well as X-rays for musculoskeletal related complaints. I should note that many respondents felt that graduating ED residents should also be more familiar with CT as opposed to MRI. We did ask about that, especially the head CT when briefly looking through and considering whether or not to give TPA for suspected stroke, or whether or not one is able to identify emergent pathology that likely shouldn't wait on a read from a radiologist before getting the appropriate consultant on board. For example, gas on a CT of extremity. In conclusion, a minority of EM residency programs have formal training in radiology, despite the majority of program leadership believing that these skills are important, and the most important curricular areas were identified in this study, which may inform the development of future radiology curricula. Thank you so much for your time, and have a good rest of your conference.
Hello, I'm Dr. Joni Shao, Assistant Professor at the UCLA School of Medicine, affiliated through the Greater Los Angeles VA. I'm presenting our abstract on the Systematic Online Academic Resource Review, also known as SOAR, on the topic Endocrine, Metabolic, and Nutritional Disorders. I have no financial disclosures. During your last ED shift, did you look up a medical topic on the internet? How often do you ponder about the quality of the content you read? Before you fire up that next great post on the approach to DKA, would you like to know what's already out there? Use of and reliance on free online medical education, also known as FOAM, is the new normal. 98% of EM residents use FOAM more than 1 hour a week. There's a ton of content out there, but it's decentralized and lacks peer review. Figuring out what's high-quality content can be extremely challenging to learners, educators, and users. This is the second entry in the SAEM SOAR topic review series. In this series, we aim to systematically identify foam's current coverage of EM topics and subtopics, assess the quality of these resources with a validated tool, and collate links to identify high-quality foam in a user-friendly framework. For the second entry, we evaluated foam for the topic endocrine, metabolic, and nutritional disorders, which is a category derived from ABEM's 2016 and 2019 model of the clinical practice of emergency medicine, which I'll abbreviate as CPEM for the rest of the presentation. First, we use the CPEM topics headings and subheadings as keywords for the database search. We also derived other terms related to each topic and compiled a final list of 264 key search terms. Using a novel software program, we inputted each term into two search engines, Google Foam and the top 50 sites of the social media index. The program automatically extracted and collated the top 100 results from each engine. A total of 36,269 resources were initially found. After removing duplicates and journal articles, we were left with 9,751 resources. Next, 4 reviewers screened the entries for relevance to the CPM topic as well as to emergency medicine. We excluded audio-only podcasts, image-only, non-English, paid content, and retagged posts. We also excluded resources that may be better categorized and reviewed in another CPM category. For example, ultrasound is its own category in CPEM. Therefore, resources primarily discussing the use of ultrasound in assessing volume status were not included. Reviewers met multiple times for consensus building. Our remaining count totaled 1,159 resources. After a secondary screen with full text review of the resources, we were left with 739 final resources that met all our inclusion criteria. All subtopics listed in the CPEM guidelines were at least covered once. As these graphs show, topic and subtopic coverage was uneven. Fluid and electrolytes lead in topic coverage with a 42% of all posts. It's followed by a far second place by glucose metabolism at 16%. The most underrepresented topic was parathyroid disease at 2.3%. Among subtopics, potassium disorders was the most highly represented, constituting 36% within its own topic category, and about 15% of all posts. The final 739 resources were evaluated with the R-metric scoring tool. The R-metric tool is a series of 7 questions meant to evaluate content, credibility, and peer review. Each question is rated from 0 to 3 for a maximum of 21 points. 4 reviewers underwent 2 rounds of tool rater training. The average measures intra-class correlation coefficient was 0.91, indicating a very strong inter-rater reliability. Our metric scores range from 1 to 19 with a mean of 11.4. Scores greater or equal to 16 were considered high-quality resources as determined in the first entry to the series by a modified Engolf method. For the second entry, we found a total of 118 high-quality resources. The table outlines the subtopic distribution of high-quality posts with their corresponding total posts. Despite potassium having almost twice the number of posts compared to all other topics, the subtopic with the most number of high-quality posts was hypovolemia with 17, followed by potassium with 16, and DKA with 12. In short, we systematically identified and curated foam resources for EM trainees and other users on the topic of endocrine, metabolic, and nutritional disorders. A final list of high-quality resources can hopefully guide trainees, educator recommendations, and foam authors. An abbreviated list of high-quality posts is listed on this slide.
Hello, everyone. My name is Eric Picard. I'm a first-year resident in emergency medicine at John Peter Smith Hospital in Fort Worth, Texas. The paper I'm going to be talking about today is called The Influence of Patient Perception of Physician Empathy on Patient Satisfaction Among Attending Physicians Working with Residents in Emergent Care Setting. Now, before we go any further, I'd like to start off with a quote. The patient, though conscious that his condition is perilous, may recover his health that simply through his contentment with the good of his physician. Now, this quote from Hippocrates, dating back to ancient Greek times, shows the importance of effective and empathetic communication with patients. Studies dating back to the 90s show that empathetic communication by a physician is one of the main things that patients look for. And when patients believe that their physicians are empathizing with them, they are more likely to convey potentially useful diagnostic information and are more likely to adhere to treatments. So it's very important to convey empathetic communication to patients. This has been studied in large part in general patient interactions. However, in an academic center, this really hasn't been studied. In an academic center where attending physicians are working with residents. The question our study attempted to answer is, how does working with residents affect A, a patient's perception of the empathy of their attending physician, and B, a patient's overall satisfaction with the care they're receiving, specifically their overall sense of satisfaction toward their attending physician. So the methods we used here. This is a secondary data analysis from a prospective single center observation study. Patients were taken at JPS Hospital in Fort Worth, Texas, which is a level 1 trauma center seeing approximately 130,000 patients a year. Patients were asked a total of 6 questions, 5 of which were taken from the Jefferson Scale of Patient Perception of Physician Empathy score, which is an externally validated scale of patient empathy. A total of 5 questions are on this, each one with a score of 1 to 7, giving a total maximum of 35 for patient perception of physician empathy. The 6th question on the patient survey was just a scale of 0 to 5. How satisfied are they with the care that they've received? The patient surveys were then divided into 4 groups. Patients seen by attendings working alone, patients seen by attendings working with first-year residents, patients seen by attendings working with second-year residents, and patients seen by working with attendings working with fourth-year residents. Now on to the results of the study. After exclusion criteria were met, we were left with 351 patients filling out criteria. The JSPPPE scores of physician empathy toward their attending physicians working with patients was the same for the group of attendings working alone and for working with interns at 30.1 on the JSPPPE score. However, this scale of patients' perception of physician empathy decreased when attending physicians were working with second and third year residents. Second-year residents, the second-year resident group was associated with a score of 29.6, and the group of attending physicians working with third-year residents was given a score of 27.8. Now, if you draw your attention to table 3 on the poster, the first column here really shows this, that there's this decrease in patient perception of physician empathy amongst attendings working with more senior residents. However, if you draw your attention to the second column here, we really don't see that drop off with satisfaction toward attendings. In other words, patients' overall sense of satisfaction is the same whether the resident is an intern, a second year, or third year working with attending. So the main takeaways from this study are that in an academic center, working with senior residents is associated with a decreased patient sense of their attending physician's empathy. However, interestingly enough, there is no associated decrease in the patient's overall sense of satisfaction. Now, this paper viewed this correlation, but future studies are necessary to identify any potential causation and also to ask why that causation could potentially exist.
Hey, what's up, fellow virtual SAEM 21 attendees? My name is David Ebbett. I'm a third-year medical student at Thomas Jefferson, and I'm very excited to share my project, Preparing Students for Uncertainty in the Clinical Practice. All right, so let's get into it. So a little bit about uncertainty in clinical practice. The transition from preclinical to clinical can be very challenging for students. Med students encounter situations where diagnosis can't be made, treatment recommendations are at odds, social determinants complicate management. So in our study, we aim to capture how students felt in various clinical situations, and we wanted to identify the type of educational programs that they found helpful as they work through these clinically uncertain situations. So what does this have to do with emergency medicine? So the emergency department is replete with situations of clinical uncertainty. This is valuable as an application for the data that we've collected in our study, as well as a potential source of further data as we evaluate how students prepare and adjust to clinically uncertain situations. So our study had three main objectives. It was to describe the perceived comfort with uncertainty of students, to identify curricular elements, and then finally to solicit suggestions from the students themselves. The overarching goal was to reflect on the data and the student experiences to help guide curricular design to help students prepare for clinical uncertain situations. To create our research questions, we used two models as a guide. The first is self-efficacy, the second is intolerance to uncertainty. So self-efficacy is defined as the confidence to carry out the courses of action necessary to accomplish desired goals. This has been increasing interest for students and medical educators. The second is intolerance to uncertainty, which involves dispositional characteristics from a set of negative beliefs that can involve the tendency to react negatively emotionally, cognitively, and behaviorally to uncertain situations. So this helped guide our creation of questions and our research. Additionally, we used previously studied validated models for self-efficacy and intolerance to uncertainty. So our study involved, it was an observational cross-sectional study with 289 third-year medical students that were surveyed at the end of clinical clerkships. We included the general self-efficacy scale and tolerance to uncertainty scale, as well as additional questions related to clinical uncertainty and curricular elements. To analyze the data quantitatively, we used Spearman's correlation coefficient, chi-squared, and ANOVA. We used Braun and Clark six-step framework model to create themes for the quantitative section of the data. For the results, we had 99% response rate. As expected, self-efficacy and intolerance to uncertainty were inversely correlated. We also compared self-efficacy to 4 domains of uncertainty and found that they all had positive ratings. This included preparation, confidence, forming meaningful relationships, and overall student well-being. Intolerance to uncertainty had a negative correlation with these 4 elements. Additionally, we found that certain modalities, pedagogy modalities, had statistically significant correlations with certain domains of uncertainty. So the full list is here, but for example, clinical debriefs had a statistically significant relationship with students' ratings of preparation and patient relationship, talking about experience correlated with patient communication, small group communication skills correlated with well-being. Qualitatively, the students described reflection and open emotional vulnerability from professors and clinical staff, as well as they appreciated small group learning, simulation, debriefing, among others. So taking all of the information that we gathered into account, it suggests that by strategically integrating educational modalities that align with humanities, with case-based learning, with frequent discourse about uncertainty in the preclinical and clinical environment, this may have a positive impact on students. Might help with their self-efficacy and in the process help with their overall well-being. Further study, of course, is required to evaluate these findings. And thank you so much for your time and attention. Feel free to contact me at my email there or anyone on our team. Thanks so much for your time. Have a great day.
My name is Mohammed Wasim. I'm a pediatric emergency physician at Lincoln Medical Center in the Bronx, New York, and I'm pleased to present this abstract on behalf of New York ASAP Research Committee, the impact of COVID-19 pandemic on emergency medicine residency training program in the New York state. we do not have any disclosures. On March 11, 2020, World Health Organization declared COVID-19 as a global pandemic, and many of the emergency medicine programs were given emergency status. New York was the first and the most severely hit epicenter during the pandemic, and New York has the highest number of emergency medicine training programs, which are mainly concentrated in the city areas. The purpose of this study was to assess the impact of COVID-19 pandemic on the training and experience of emergency medicine residents. This include clinical, didactic, and research activities of emergency medicine residency program in the New York State. This was a cross-sectional survey of the New York emergency medicine residency programs. This survey was designed by the members of New York ASAP Research Committee. The survey contains questions which assess the impact of COVID-19 on the training of emergency medicine residents, including clinical, didactic, and research activities. We distributed the survey to the leadership of the program in May 2020 using SurveyMonkey. The survey was sent multiple times to optimize the response rate. In terms of survey, just to show an example what was in the survey, there were questions about the rotations, about their weekly conferences, and about the research, and also a question about resident wellness. In terms of response rate, 22 programs responded out of 29, which is 76% of New York State emergency medicine residencies. 17 programs, which is 77%, were aware of their emergency status. In terms of participating program, 15 programs were either academic or university program, and 7 were community programs. In terms of duration, 13 programs were of 3 years and 9 of 4 years duration. In terms of location, most of the programs are located in the city area, 68%, and 1 program was in rural area. The impact of COVID-19 by program type, most of the program reported either moderate impact or high impact. And this was evident by program duration, hospital setting, and location of the program. In terms of educational impact, all programs quickly adopted virtual format for their conferences. 2 programs reported they limited to a small group or modified to self-directed learning method. In terms of research, half of a program reported that prospective research completely stopped. 28% use either video or phone service for consenting. And in terms of retrospective research, 32% program reported that retrospective research continued. In terms of rotations, the internal trainees of service rotations were severely affected, 95%, and outside trainees visiting rotations were moderately affected. In terms of wellness initiative, many programs obtained donations by outside companies, 95%, and 58% program reported that hospital facilitate or paid for these services. Virtual social gathering were scheduled by 79% of the program. 37% program reported that they moved their resident from high stress area, and 42% program reported that they reduced the workload for the resident. 47% reported that they established a wellness area or respite space, and 26% added a virtual class for yoga or meditation, and 42% planned for future activities. So conclusion, the COVID-19 pandemic has transformed the education for emergency medicine residents in their training program. Resident learning continued using innovative methods even during this difficult time. Emergency medicine programs were able to overcome the challenges of this pandemic. Essentially, all programs transitions to virtual format for their conferences. Many off-service rotations were cancelled or postponed. The allied health professional students were not allowed to rotate through the ED, and many research activities, particularly prospective studies, were stopped or halted. So how do we use this information? New York State programs have demonstrated that education can continue despite external limitations and challenges. Although training programs were nimble in making educational adjustment, we will not know the true impact for many years. This is important that programs should consider designing educational disaster plan that can be implemented immediately in the event of another disaster. Thank you.
Hello, everyone. My name is Teresa Chan, and I'll be presenting to you about a programmatic needs assessment process for creating the Armed Med-Ed course, the CLAIM methodology. Very delighted to be invited to speak to you about this, and I thank the SAM board for being so supportive of the Armed Med-Ed task force and the subsequent course. The study team is as listed here, and I would like to thank each and every one of them for all their hard work in making this project a success. I would like to note we are also presenting on behalf of the Emergency Medicine Health Professions Education and Research Consortium. The medical education landscape has shifted greatly. There's increased professionalization, higher expectations of editors and reviewers of journals, and these pressures are increasing the need for continuing professional development in the area of medical education research. This is a highly competitive space, with medical education fellowships all over the place and master's programs popping up everywhere. When designing a med-ed course then, we wish to take a more scholarly and robust approach to designing this new type of course to make sure that we were mapping to the needs of our participants, but also analyzing the world around us to make sure we were filling a gap. To do so, we created a novel programmatic approach to the needs assessment process. Rather than conducting a single-pronged approach, such as just sending out a survey, we took a note from the world of programmatic assessment, where you actually take multiple different assessments and combine them together. And so we designed this method called the CLAIM method. And so C stands for competitive analysis, L stands for literature review, A stands for asking stakeholders, and in our case, we did this via a national survey. I stands for internal review by experts, and M stands for mapping of a curriculum. We took about 12 months to do this whole process. And it was an 8-person team that took the 5 steps and completed them into 3 different phases. In phase 1, we engaged in the discovery phase. In this phase, we conducted a competitive analysis and also a literature review to see what had come before. The competitive analysis included a review of existing programs that we respected or had actually taken ourselves. And the literature review looked at the literature around what other people had written about the needs of those who were engaging in medical education research. We combined both of these documents to create 2 new things in the convergence phase, which is phase 2. In this, we used the literature and competitive analysis to ask key stakeholders what they were looking for. We also then took the results from that stakeholder analysis and asked everyone to vote and actually review the content within our expert consultation team. So that was our 8 individuals that I've listed earlier, plus a few others who are part of the MedEd task force that was assembled to create the ARMED MedEd course. And finally, we took all the values and the suggestions from both the stakeholders and the internal review process to actually map out the curriculum and actually put everything together. This was done in the synthesis phase. Our results were that during the competitive analysis phase, we identified 17 programs that we should actually audit and see what they've done. A literature review was completed, which found 31 papers of relevance. This included a call to social media to see if there were suggestions, and we found several in there. We also were suggested to look at an entire collection of papers, specifically the Perspectives on Medical Education Writer's Craft series. We also asked our stakeholders during a national survey to see which of the following content that were found in the competitive analysis or literature review might be best targeted to their needs. Next, we also found that in internal review, we were able to find a number of items that were definitely highly valued by our team as key areas of development that we needed to focus on. And this happened with our internal review. And then finally, this resulted in 15 curricular items that we took under advisement when developing the new ARMED MedEd course. In conclusion, a programmatic approach to curricular needs assessment may yield more robust data to help you design a course that's more complex and more nuanced. And this might be better than a singular method. Our method, we think, can be useful for other people who engage in faculty development or continuing professional development, and could be used in other domains and topic areas. Thank you.
Thank you to SAEM for this opportunity to present our research. My name is Eric Lee. I am Assistant Clerkship Director at Maimonides Medical Center in Brooklyn, New York. My co-authors are Dr. Shivani Modi, Assistant Program Director, and Arlene Chung, Residency Program Director. Our research abstract today is entitled A Qualitative Needs Assessment of COVID-19's Impact on EM Interns. We have no disclosures. The incoming class in July 2020 was the first graduating class to experience the impact of the COVID-19 pandemic on their residency, training, and medical school education. They started residency with less clinical experience compared to their predecessors, and during a time of great need for skilled healthcare workers. We believe that these unprecedented conditions would have a significant impact on the training and experiences of these new doctors. We saw through this study to characterize the impact that the COVID-19 pandemic has had on the well-being and educational experience of this class of trainees. We wanted to better understand what their thoughts and concerns may be so that we would be able to tailor resources and support appropriately for their particular needs. During their orientation month, we conducted a 1-hour semi-structured focus group interview with our intern class. This session was voluntary and open to all 18 interns. A recording of the interview was transcribed and de-identified to preserve the anonymity of the participants. Using qualitative methods, initial coding was performed independently using an inductive and iterative process by 2 study authors with experience in qualitative methodology. Once saturation was achieved, final codes were reapplied by initial coder and a 3rd author. After consensus discussion, agreement reached 100% and codes were grouped for thematic analysis. We identified two major recurring themes: education and professional identity formation. Nearly 40% of the comments centered around concerns regarding the quality and breadth of their medical education during the COVID-19 pandemic. They were uncertain if their medical education had been significantly compromised by the distance learning imposed by the pandemic, but they were wary of the additional challenges that virtual didactic education and social distancing would have on their residency training. They were also concerned that they would see many COVID patients and not enough bread and butter emergency medicine. The other major theme that emerged was focused on professional identity formation, which accounted for nearly 30% of comments. The start of residency has always been a personally formative period of time in a physician's training as they finally begin to take on the responsibilities that they have so long worked towards. The pandemic added layers of complexity to this important period of time, as the role of physicians and other healthcare workers was constantly highlighted and discussed during the pandemic. Several spoke about coming to terms with the politicization of medicine and the complicated role that physicians now played as public health educators and advocates during a pandemic. They also expressed discomfort with the healthcare hero label and narrative that was popularized in mainstream media during the height of the pandemic. These are representative comments from each of the themes we identified. Other minor but significant themes that we identified include mental health, physical health, and grief related to COVID-19. As medical educators, we are particularly invested in supporting the mental and physical health of our trainees. Many participants, like most other healthcare workers during the pandemic, expressed fear and concern for their safety, as well as the health and safety of their families. Interns also reported experiencing several unique challenges to their emotional and mental health, including the need to socially distance during a period in their training when they traditionally relied on additional support systems and built new relationships. Our participants also continually returned to feelings of loss during the pandemic, which in many ways paralleled the classic stages of grief. There was anger and sadness that the pandemic had robbed them of medical school graduations and match day celebrations that many had spent years looking forward to. Many acknowledge that these losses may seem trivial compared to the many other consequences of the pandemic, but they were significant and personal losses nonetheless. Our analysis suggests that new EM interns have significant concerns about their medical knowledge and the quality of their education, as well as their identity as emergency physicians and public health advocates during the COVID-19 pandemic. EM interns also reported unique challenges to their physical and mental health. These findings will help inform future decisions regarding dedicated support and training necessary for this unique group of learners. The impact of COVID-19 on medical education is ongoing. This year's incoming class will arguably be even more so impacted by the pandemic. There remains a continuing need for more research on how to best support our medical students and residents who remain deeply impacted by the COVID-19 pandemic. Thank you for your attention, and we're happy to answer any questions.